vets from around the world, so around Asia in particular, English-speaking vets that can join. We thought we'd take that chance and branch out a little bit further and open up our second webinar. So our first one we've already had, which was with Dr. Rebecca Waite, who is from Vets for Compassion, our dear partners that ACTAsia have worked with for more than 10 years now. Unfortunately, Dr. Rebecca has been called away today to an emergency surgery for septic peritonitis. I hope I've got that right. So Rebecca will not be able to join us. Sends her apologies and all best wishes to all of the vet trainers and all of the vets that she knows that are on here today. So today we have myself, I'm Dawn Peacock from ACTAsia, and I am very happy to introduce Annie, who will be our, she is one of our amazing vet trainers, and Annie will help us with the Q&A section at the end of the lecture. So we'll do about an hour of lecture and then 30 minutes, very interactive. So if you've got questions or something didn't quite make sense, or you want to ask about a particular case study, we'll have 30 minutes after the lecture to go through that. And Annie will help if we've got any questions in Chinese. And for the first section, like I've said, we've got Ed, who is fantastic and will help us with the translation for the first hour. But really, the showcase today is to introduce Dr. Keiren Maddern. Dr. Keiren, have you got a video? Do you want to?
I can. I'm just going to turn the video back on again.
Yeah, that's great.
Here we go. You can
Oh,
see
lovely.
me with my lovely noise cancelling headphones. I have a small child in the house, so I'm going to apologise in advance for
wear them all the time.
Yeah.
So
hi everyone.
I'll introduce you as per your bio, but please jump in because there's so much. This goes over 20 years, so there might be things that you want to add in here. So I've got that you're a European boarded specialist in anaesthesia and analgesia, with a particular interest in animal pain, and strives to improve awareness of this problem and also deliver high-level care for pets in pain through provision of state-of-the-art perioperative analgesia and chronic pain management on an outpatient basis. So this has obviously been a real passion for you throughout your career. You've graduated in 2000 from the University of Queensland, and following that you went into general practice at the University of Queensland Emergency Centre and at the University of Sydney as a clinical registrar in veterinary anaesthesia. By 2005, Dr. Keiren became a member of the Australian and New Zealand College of Veterinary Scientists in the field of anaesthesia and critical care. After that, he completed a senior clinical training scholarship at the Animal Health Trust in Newmarket in the UK. Hooray for England, we got you over here. And then you became a diplomat, is that right? Diplomat of the European College of Veterinary Anaesthesia and Analgesia. So you really are worldwide. This is a big international expert that we've got.
In lots of places.
Yeah, including since 2010, you've lived in Singapore and worked in Hong Kong and China. I'm sure that our delegates today will want to know where in China, just in case any of them are there.
Have we got anyone from Chengdu?
Anyone from Chengdu?
Or from Shanghai?
I'm sure we must have. I've still got a hand up in there, but I'm not sure if that's for this or from earlier on. But we'll carry on. But that's both sides, right? That's Chengdu's on the west and then Shanghai on the east. So we've got good coverage there as well. And you've continued to provide anaesthetic consultancy services within the Asia Pacific region. So even before this, you've already been raising awareness of chronic pain and the link to animal welfare through your work anyway.
Yeah, it's I mean, pain management and welfare are, they're synonymous almost. When you look at the 5 freedoms that we have, freedom from pain is a huge one, and also obviously having access to the things you need to live. But I think that everyone could do a lot better job at recognizing pain in our companion animals and looking at what we can do to treat that, which is quite a lot.
Yeah, absolutely, absolutely. So I will hand over to you now and close my video so that it's not in the way there. And yeah, as we go through the lecture, if you've got questions and answers, I'll be on standby there. Or if you want to wait to the last 30 minutes for other bits and bobs to ask Dr. Keiren, we've got that time as well. So I'll hand over to you now, Dr. Keiren, but I'm here if you need anything.
Fantastic.
Okay.
I'm just going to share my screen and see if this works.
Yes, lovely. Do that.
Fingers and toes crossed. And I want to share this one. And I want to okay, is that coming up okay, or is there still a file in the middle of it?
Haven't got it at the minute.
Okay, now let's try this.
Yeah.
Screen sharing has failed. Please try again later. That's not ideal.
That's not. Let's see if I can do anything. So I've got all panelists can share. Let's see if that, let's give it another try.
Okay, let's try again.
That's working.
Okay,
perfectly.
that's working now?
Got it.
Fantastic.
Yeah.
Okay, there we
Lovely.
go. So that should be all up and running.
Brilliant.
Okay, so everyone can see me and hear me okay?
Any problems, please use the chat box and we'll be here. But I think we're fine.
Okay, so welcome everyone, and thank you to ACTAsia and Vets for Compassion for giving me the opportunity to talk today. I'm very, very grateful to have the privilege of being able to share what I know. Now, over here, okay, so for our delegates in China and anyone else who speaks Mandarin, 你好，谢谢你看家。对不起，我的中文说得不太好，我会说英语。这是我的腊肠狗。So this is my dog in Chengdu. This is Rupert. And hopefully you could make some kind of sense of my abysmal Chinese. And welcome to the talk. What we'll do today is go through a few different areas of chronic pain management. And what I'd like to start off with is to introduce what is pain, and the International Association for the Study of Pain, I define it as being an unpleasant sensory and emotional experience associated with actual or potential tissue damage. And the sensory and emotional part and the actual and potential part are really important when dealing with chronic pain, because pain, particularly when it's been around for a long time, will affect us and will affect animals in terms of both of their sensory system, and it's going to have an emotional and behavioral impact as well, which is really important to address. The other thing with chronic pain is that it may be in response to actual tissue damage, or in some instances, there may not actually be any obvious tissue damage there, and it's things like fibromyalgia can cause quite marked pain and fatigue, and there's not actually a lot of pathophysiology or pathology there to associate with it. So now we can have a little bit of an overview here. So today we're going to look at 3 different components to looking at and managing pain, in particular chronic pain. First of all, we're going to look at what chronic pain is and try and differentiate it from acute pain, because they're very, very different, although they do dovetail in, but they are very, very different entities. And secondly, we're going to look at how to diagnose chronic pain in our veterinary patients. Now, there's some subtleties to that, and it's a lot more difficult than diagnosing pain in a human, but it's definitely within the realms of possibility and actually quite achievable in clinical practice. Then finally, we're going to look at options for treating chronic pain. And I'm not going to be here to list out a whole heap of medications that you can use. If you'd like to have information on the medications and dosing and other information, there's a fantastic set of guidelines available, and they've been published by the WSAVA pain management group, and they're free and available on the internet. I will share a guide to those a little bit later. So if we hop over to our first point as to what is chronic pain, we're going to do a quick review of the pain pathway, and then we're going to dissect the features of chronic versus acute pain. We're briefly going to mention several types of abnormal sensation that pain can cause, particularly chronic pain, and just touch on some of the different types of pain. Pain is an umbrella term, but there are actually different types of pain originating from different pathophysiology. And I think that the biggest thing to take home from this today is that pain has a massive impact on the well-being and behavior of our patients. And that's something that we can definitely help to address through not just focusing on medication, but focusing on well-being as well. So we have this lovely diagram here of a fantastic sausage dog. I'm a little obsessed with them. And now let's see if I can use my pointer here. No, it's not going to work. What about over here? Nope. Okay, so we're without pointer at the moment, but we'll see what happens. So what happens is, if you can see down in the dog's foot there is a nerve ending called a nociceptor. And that is the part of the body that will pick up a noxious stimulus. And generally a noxious stimulus can be a physical or crushing, cutting stimulus. It can be a heat stimulus. It can be a chemical stimulus. And what the nociceptors do is they will transfer that into a electrical signal that's called the transduction part, which is over there near the side of our patient. Then the nerve fiber will transmit that signal up to the dorsal horn of the spinal cord, and the little red segment there in the middle represents modulation of that pain signal. And the grey matter in the spinal cord can either amplify or can downplay the pain signal, kind of like an amplifier in a music system. You can have your signal going in from the microphone. It will then either be amped right up by the amplifier, and you can control the setting of that signal by controlling the amplifier. So that's a very important point to come back to later. Then the purple line represents a secondary neuron, which leaves via the contralateral ventral horn of the spinal cord. And there are numerous tracts that project up to the brain. So one of them being the spinothalamic tract. And up in the brain, we have perception. Now, there's conscious perception, which happens in the cerebrum, but there's also other effects that happen in the hindbrain as well that can cause, abnormalities in physiology as well as our conscious perception of that signal. What can also happen is that there's a phenomenon called descending inhibition, and the brain and the spinal cord and all of the nerves are a very plastic system, and they are subject to change. And what we'll do next is we're going to look at acute pain, which is more or less this kind of simple loop that we have a unpleasant signal transferred up through the spinal cord to the brain. The brain then sends a signal back down and tells us, ouch, that hurts, pull your foot away. But things can go wrong. So if we were to look at acute pain, it's kind of what you would call the normal type of pain. So acute pain is a symptom of a disease. It is of short duration. Oh, here we go. My pointer's come back. There we go. Hang on. Sorry, let me bring that up. So it is of a sudden short duration. Typically, it will resolve with tissue healing. It's a warning sign to the body that there is potential tissue damage happening. And usually, but not always, it's proportional to the degree of tissue damage that occurs. And ideally, in short-term pain or acute pain, we get minimal CNS changes, and we don't get a lot of long-term disruption to behavior and sleep and anxiety. The thing with acute pain is that if we don't treat it appropriately and in a timely manner, it can actually morph into chronic pain. And typically, if pain's been present for, they say as much as 3 months, but in my experience, it's a lot sooner than that, we can actually get a chronic pain developing. Now, chronic pain it's a disease in its own right. So chronic pain is a dysfunction of the nervous system, and it's something that will develop after exposure to acute pain, or particularly so with some types of damage like nerve damage. It's usually very tricky to spot because it has a slow and insidious onset, and it can persist even after the original injury has healed and there's no longer any physical damage that can be discerned, perhaps on a radiograph or a CT or an MRI or ultrasound. Chronic pain doesn't have any beneficial purpose. It's pathological pain. So it's something that really should not be there. And there's no potentially there's no correlation to the degree of tissue damage. It's really out of proportion to what you would expect to occur. And as I said before, it can be no tissue damage and still chronic pain occurring because it's a potential damage. And in chronic pain, we have an extensive CNS dysfunction. And it can also lead into chronic mood disorders and behavioral issues for our patients. So if we go back to our pathway again, instead of just having this simple loop up and back, we get some changes here in the periphery. We can have sensitization of our nociceptors. We can have changes in nerve conduction. We can have a lot of changes here within the spinal cord, and particularly this little red segment of the dorsal horn where pain is either amplified or damped down. And then going up into the brain, we can have chronic changes within perception and in the hindbrain as well. And we can have alterations to what we call descending inhibition, which is going back down again to modulate the pain. So there's quite a lot of changes, and these can actually be measured on functional MRIs and other types of imaging of that nature. So now, the really, really, really important bit, it's how to diagnose chronic pain. And the fantastic news is that everyone already has all of the tools they're going to need to diagnose chronic pain. It's diagnosed on physical examination, asking the right history questions of your owners, and listening to the responses of the owners and picking up on subtleties and things that maybe they don't think are important. It's very, very important to go into, or I view any patient with the assumption that they have some pain, and it's my job to disprove that they have pain. And we must work to try and exclude the possibility rather than try and find it. And I've popped a picture of a bunny here because all animals experience pain. Rabbits do too. And one of the tricky things is that in animals that are regarded as a prey species, they tend to hide their pain. And it can be a little bit less obvious to us to try and determine whether the animal's painful or not. They can appear to be very stoic. But again, when we speak to our owners, they will know the normal behavior of their pet, and they will be able to help to differentiate what changes have occurred. So we're going to look at history, examination, and looking at treatment trials as a means to try and diagnose pain. So I know I gave you a definition of pain previously, but I actually prefer this definition, and is that pain is what the patient says hurts. And there's a huge amount of individual variation in how pain is perceived. No two patients are alike, even if they have a almost identical disease process occurring. They can experience that in entirely different ways. And it's very, very important to not treat individuals of the same species or the same breed, or even, if you had two animals or people with an identical injury, their pain is not going to be the same, and we need to assess the individual. Now, the next slide, we're very lucky to have some people on this slide here. This photo is of a very special patient. His name is Keo, and I was very privileged to be able to work with his mum and dad to help with management of his painful tumour there. And one of the things that is really important is to talk to the people who interact with our pets the most. It's really important to spend some time talking to them, listening to them. And when you know what to look for in terms of subtle signs of pain, it becomes a lot easier to try and differentiate. Now, there is no diagnostic test for pain because it's such a variable experience. Most of the information we can get is from our history of how our patient has changed over the course of time. There's a bit of an art in recognizing the subtlety and asking questions about how the patient's behavior has changed. Either, perhaps looking back to since the patient was a young animal, whether they've slowed down, whether they maybe have signs that would be attributed to old age. They're things that we look for are their interaction with the people that they spend the most time with, whether they seek attention, whether they seek an affectionate interaction, whether they exhibit play behavior, whether they are changing in terms of their appetite, their willingness to do activities that they would typically engage in. Other questions to ask are around the activity of the patient. Are they able to move around in a manner that is typical for them? Are they able to jump up? Do they enjoy walking? Do they have trouble getting up or lying down from resting? Do they have any inability to do things like squat to urinate and defecate that they may have been able to do previously? And I'll just move on to the next section, which is looking at our physical examination. Oops, come on, slide. There we go. Now, the physical examination is the second part of identifying pain. And generally what we want to do is start with a distant examination of our patient. We want to look at the patient from a little way away, and we want to look for anything that could be abnormal before we start interacting with them. We want to look for any evidence of lameness, any gait changes, unusual ways of sitting or standing, unusual posture. We want to look for asymmetry in the patient, where maybe there's a change in muscle tone. Then after we've examined all of that, we can also look at how our patient's breathing, what their demeanor is like, whether they're alert and responsive, or whether they're dull and kind of not engaged with their surroundings. We can look then for any obvious pathology. If there's a fracture that's been there for several months, that's an obvious source of chronic pain. If there's osteoarthritis and severe osteoarthritis, that can be indicated of chronic pain also. One point I want to stress is that if there's not anything obvious that could be causing pain, it doesn't mean that there's not pain there. It just means that we haven't identified it, or the patient's system has amplified the pain signal from something that's very benign to something that's quite pathological and caused the chronic pain. So what I'll do next is, with my examination, is I'm going to do a gentle palpation and manipulation over the whole animal. I'm going to run my hands over them. I'm going to feel what the muscle tone is like, whether there's any response to me palpating the patient. We want to look for very, very subtle signs of reaction, because potentially if they are at a veterinary clinic, they might be very stressed and they might be trying to hide their pain because they're very, very worried about what's going on. They may have had bad experiences at the vet in the past. So trying to put your patient at ease while examining them or doing things in a neutral location is really important. So what we're looking for are subtle changes in facial expression of the patient. Maybe they turn to look at you when you hit a sore spot. They might just move their head to look subtly at you. They may express some licking of their lips as an anxiety behavior. And at the other end of the spectrum, they may show really markedly avoidant behaviors and try and get away from you, or just demonstrate aggression when they have a sore spot that's palpated. As I mentioned before, feeling the muscles and feeling the tissues and feeling for any changes can be very important. We can look for signs of lack of use of muscles, muscle wasting. We can look for hair coats that are in species that groom themselves, like cats and to a lesser extent rabbits. We can look for a rough hair coat. Maybe they don't want to groom themselves, or maybe they're physically not able to groom themselves, and getting around to reach their back and other areas is uncomfortable for them. Then the other thing to look out for is over-grooming or continuous licking of a specific area. Now that can be due to irritation, so dermatological conditions, but it can also be if you have a patient, say, licking at their carpus or tarsus in a continuous manner. That could actually be because there is a painful stimulus or a painful area underneath the point they're paying attention to. And oops, hang on, sorry, I've moved too forward too quickly. There are a list of questions that I do have available. It's a survey that I hopefully will have translated into Mandarin at some point. It's a questionnaire to go through all of these different physical or more historical questions to try and get a sense of how the patient's doing. Now, I think the other thing that after we've examined and after we've talked to the people that know the animal the best, sometimes if we're not sure whether there's pain or not. If our gut feeling is saying that this patient could be experiencing pain, we can do a thing called a treatment trial. And if we're not sure if there's been any improvement after instituting the trial, we can change the trial up. We can think about what the type of pain could be. And I just realized that I didn't actually tell you the different types of pain. I think am I missing a slide? No. So if we institute a treatment trial specific to the type of pain that we're targeting, and be reasonably aggressive with our treatment trial and seeing at the end of that whether there's been an improvement in the signs that we've noted in our physical examination and history taking, then that can be a good way to diagnose pain as well. And just jumping back to the different types of pain that we can see. So back to the pathophysiology slide. I'll go back here. There we go. So I think that there's the regular types of pain. So if you have some kind of tissue injury, there's injury to specific types of tissue. So perhaps if we have a nerve injury, we can get neuropathic pain, which predisposes quite markedly to chronic pain. And that's got its own very specific set of sensations that can come along with it. Other types of pain are cancer pain, when we have a tumor that's releasing a whole heap of, noxious material, cytokines and inflammatory mediators, and into the system of the animal. And cancer pain is very different in that it's, it kind of perpetuates itself. It not only is there a pain focus, but there's a lot of mediators being released that will amp up all of the signals. And then finally, I think there's inflammatory pain when we've had a chronic inflammation occurring. So each of those three things, there's quite specific things that you can do to treat the cause of the pain. And then also with the different pain sensations, we can have allodynia, which is touching an area that with a stimulus that would not normally be painful. So maybe a gentle patting touch, and that's perceived as a painful stimulus. We can have hyperalgesia, where we have a painful stimulus, and that's put into our nervous system that's already sensitized. And what might be a tiny bit painful is actually magnified up into an excruciatingly painful signal. And the other type of nerve dysfunction that we see sometimes in chronic pain is paraesthesia, where you get unusual burning and tingling sensations, which wouldn't occur normally. Now, if we jump back. So we're going to move on to the next section, which is treating chronic pain. And as I mentioned previously, it's going to be more of a holistic focus on all of the things we can do to try and help our patients once we've identified pain. And there's 4 components to that I try and remember. There's medication and medical interventions, physical therapies, exercise, and behavioral therapies. So there's quite a lot we can do outside of just prescribing some medication. And another favorite quote of mine is, do what you can, where you are, with what you have. And when that comes to treating pain, there's actually a lot we can do, an awful lot we can do without a lot of physical equipment. So we'll go through this. We're going to start with medication. We will then move on to some physical therapies, exercise, and behavioral therapies. It should say behavioral therapies rather than modification. So as I mentioned, we have a whole heap of different medications that we can use to treat our patients who may be experiencing pain. And some of these are available widely and others are quite restricted and may not have free access to, depending on where you're located. So I'm going to mention all of them just really briefly, but I'm going to focus on the medications that are more widely available and how we can utilize them to their maximum benefit for our patients. So I guess before we start on medications, there's the obvious that if there's something we can do to treat the source of the problem, we should do that. If there's a broken limb, we should stabilize it. If there's the possibility that a tumor can be removed or debulked, we should do that. If there's something we can do secondarily to try and modify the disease process, such as perhaps improving the joint health in the case of osteoarthritis, or perhaps treating a tumor with metronomic or very low dose interval chemotherapy, or treating a bone tumor with agents that are going to reduce the lysis of the bone. We should do all of those things before we even begin to think about what pain management we're going to do. When I say before we think about it, we should be doing all of these things concurrently. But if you can do something to fix the problem, start planning to do that at the same time as instituting appropriate medications. The other thing about medications is that we want to do something called multimodal analgesia. We want to combine many treatments that have synergistic effects, and we want to use them all together to try and reduce any adverse effects that any one medication may have. And we want to try and maximize the targeting of the different areas within the central nervous system that are affected by pain. Now, when I think of multimodal analgesia, I think straight to food. So I usually use a food analogy for multimodal analgesia. And what I would say is that you want to start with something to eat. So that something to eat might be a bowl of plain noodles. It'll probably do the job, but it's not as good as it could be. So what we want to do then is maybe add some sauce to our noodles. We might want to add some seasonings. We might add some chili or chili oil. We might want to add some sesame oil, some vinegar, maybe some spring onions. And at the end, we're going to get something that makes us feel a lot better and is much better than any one of those things on their own. The other consideration I have when looking at chronic pain is remembering back to our diagram that we may have a lot of changes within the central nervous system. And what we might do to treat an acute pain patient may not be anywhere near enough to even touch the sides of a chronic pain patient. So often what I'll do is start with quite high, I guess, quite aggressive rather than high level pain therapy, and then trial that for 1 to 2 weeks and then start to reduce it and to see what effect has occurred after, I guess, trying to get some of the central sensitization and central changes under control by reducing the signals that are amplifying that and perpetuating that central change. Now that can be hospitalizing the patient and giving an infusion of pain medication, so something like a lidocaine infusion. It can be providing a lot of different medications all at the one time. And it can be maybe doing something to relieve the pain temporarily, like a local anesthetic nerve block. And after we've treated that pain very, very intensively, what we want to see is a change in our patient's behavior. Now, with the types of medication that we can use, I'm just going to run through them. I'm not going to give specifics and doses. I'm just going to talk very loosely about the different types we have here. Probably the first thing that I will reach for in most cases of pain are non-steroidal drugs, because they are readily available, they are well tolerated by most patients, and they are very effective in targeting the inflammatory component of the pain, as well as some of the more central effects. I know that many of us are concerned about using non-steroidals in the long term, particularly with animals such as cats or elderly animals. It's definitely possible to monitor their effects on the kidneys and other organs by looking at blood tests on a recurring basis every couple of months. But I think these have the greatest potential to alleviate pain in an accessible manner, and certainly the first line of treatment that I would reach for. If you do have a patient that is, for whatever reason, not able to tolerate non-steroidal drugs, an alternative would be to trial paracetamol. Now, this is just for dogs. I just want to stress that paracetamol is toxic to cats. We should not give paracetamol to cats under any circumstances. So if you have a canine patient who, for whatever reason, can't have non-steroidal, you can give them paracetamol, which I believe is very, very widely available as well. And those two drugs are probably the starting points. If there's a possibility of starting with a non-steroidal, do that. And if you can't, then the next thing I would reach for would be some paracetamol. I'm not going to go into a lot of detail about opioids because they are very, very restricted, and I'm aware of the difficulties in having access to them. If you are in a place that can prescribe opioids to your veterinary patients, then that's a good adjunct to the non-steroidals or paracetamol, but it's not the first thing that I would reach for. Oh, sorry, going back to the non-steroidals, the other thing I would mention is that if you don't have a great success with one non-steroidal in an individual patient, it's definitely worth trialing a second non-steroidal, because there's not one that is overall more effective than any other, but individual patients will respond differently to the different non-steroidal drugs. And one patient may do brilliantly on meloxicam, and another patient may do brilliantly on carprofen, and not vice versa. Coming down to the third item on our list are Nmda antagonists. These are very, very useful medications, because if you remember back to the slide with the outline of the dog and the pain pathway, there was that little red section in the middle, and that is the dorsal horn interneuron, which modulates the pain. Nmda receptor antagonists help to modulate the pain and reduce central sensitization that occurs particularly during chronic pain. Again, the most typical drug that we see is ketamine, which again is very restricted. And the other one is methadone, which also has an NMDA receptor effect. Now, both of those drugs aren't widely available, but what I believe is a lot more accessible is an oral medication, which was originally an antiviral medication called amantadine. And we can give our patients amantadine or memantadine, and that will help to downregulate that central spinal cord effect of amplifying the pain signal. Local anesthetics are brilliant. If you have a situation where you can apply a local anesthetic to a patient, then I would say do it. For chronic pain, that might be doing something more invasive, like an epidural catheter, or it might involve repeated nerve blocks, or it might involve an indwelling catheter around a nerve. And although these are somewhat more advanced techniques, they're definitely achievable for a subset of patients, and they can be incredibly effective in selectively blocking some of the sensory input, but still maintaining the motor function that the patient needs. We've mentioned paracetamol. You can actually add that on top of a non-steroidal if you have a dog that has a pain and maybe they need an extra boost for some analgesia periodically. They can have some paracetamol as well. Excuse me. The last two are that I want to mention are our steroidal drugs. Now, they're not really the first thing that I will reach for in terms of pain management, but in some specific situations where there is a marked inflammatory component, say nerve entrapment, or in some types of osteoarthritis, they may be beneficial. And finally, with our last one down the bottom, gabapentin or pregabalin is particularly helpful for neuropathic pain or pain where there has been damage to a nerve. And it's something that I will often combine with a non-steroidal, maybe with an opioid, maybe with an Nmda antagonist, maybe with paracetamol, and maybe with gabapentin altogether. Now, I've just put up a link here. This is if you scan the QR code, you will be able to get a link directly to the downloadable WSAVA Global Veterinary Pain Guidelines. And these are available in Mandarin, simplified Chinese, and they are really, really great. So I would definitely encourage you to go there and find out more about the different types of drugs in their own right. And also, I'm also very happy if I'll put my contact details at the end. If you do have specific questions about a specific patient, I'm very happy to be contacted, and usually I can translate my way through despite my abysmal Mandarin. Now, on to the next page. Looking at physical therapies that we can use to help our patients that are in pain. These are, I find, really, really, really important because often when our patients have been uncomfortable for a long time, they don't use their bodies normally. They get sore spots in their muscles, which can cause referred pain. They may lose flexibility, they may lose strength. And it's really, really vital to try and encourage movement, and to do that through some specific physical therapies. And that can be through gentle massage of the soft tissues to improve blood flow and increase flexibility. Stretching, using some specific passive range of motion stretches that we can do with our pets, or the owners can do with pets at home. Acupuncture is incredibly useful as an adjunct to medication. Strengthening exercises, we'll come back to that a little bit more in the exercise component. But effectively, what we want to do with our strengthening exercises is to improve the muscle mass surrounding affected areas. We want to improve the support that we have for any affected joints or affected areas. We can also look at modalities such as electroacupuncture and TENS, and both the TENS units are available very, very inexpensively pretty much everywhere, and it's actually very easy to apply them to our canine, feline and rabbit patients using a generous amount of conducting ECG electrode gel. and the silicon rubber or silicon carbon electrodes, and just taping them or strapping them gently to the areas that you want to apply them to your patient. And then the final thing there is using hot and cold therapy. Now, I guess as a general rule of thumb, for a patient that has an acute injury and there's inflammation going on, I would apply a cold pack to that area. But for most of our chronic pain patients, we want to try and warm the area and improve blood flow to the area. That can be done through a whole heap of different ways. It can be as simple as applying a hot pack gently to the area, warm so that we can get some heat into the sore area. We want to make sure that's not too hot so that we don't cause burns, particularly as some patients may not have as much blood flow to the periphery as perhaps healthier patients do. That can also include things like ultrasound therapy and laser therapy. I'm not going to go into that a lot here. There's certainly options available for our patients. However, there's not really strong, or I don't believe that there's really strong evidence backing their use. So I think that's definitely something to consider, but not an essential part of what our patients need. Now, exercise, again, is really vital for these patients. We want to have gentle exercise. We want gradually progressive exercise. We want to do this with the aim of improving muscle tone, getting muscles and connective tissue moving. Exercise helps to improve proprioception for our patients, and it has a very profound effect in inhibiting pain. And it also has some psychological benefits. So in terms of exercise, we want to start very gently and progress with the patient. We don't want to, I guess, push them into something very vigorous and can have concerns about them then injuring themselves further. And as you can see, this guy here is having a lovely swim. Swimming in warm water is a really nice way for dogs to exercise, and rabbits as well. Not so much for cats, but it does happen. And even gentle lead walking, doing some specific exercises to strengthen muscle groups, such as repeated sits and walking through poles, using balancing exercises are hugely beneficial, both for the physical well-being of our patients, and most animals will enjoy the psychological benefits as well. Now, that leads me on to the next slide, which is behavioral therapy. Now, there's a very important interplay between anxiety or fear and pain. They feed off each other and they have a synergistic effect. So if you're feeling painful, you're going to feel more anxious. If you're feeling anxious, then you're going to feel more pain, or you're going to experience the pain more acutely. And what we can do is to look at behavioral therapies for our pets, and also behavior modifying medications for them. Now, medications that can be used in behavior and also for pain management are some of our serotonin reuptake inhibitors, and medications that are used to increase serotonin concentrations. And I believe they're quite widely available. So amitriptyline is very useful for an adjunctive pain management medication, particularly in patients that may be suffering from their pain more so. Medications that will relieve anxiety or anxiolytic medications such as trazodone are also very helpful in managing pain, particularly in a behavioral context. And then finally, some of our alpha-2 agonists that we would typically use for sedation actually have an effect on pain management as well. we would typically use in veterinary practice either medetomidine or dexmedetomidine. I'm unsure whether the oral formulation of dexmedetomidine is available everywhere. However, that can actually be given through the transmucosal route. And another medication that can be helpful in both behavioural management and anxiolysis, and also for pain management, is clonidine, which is a human medication but is also an alpha-2 agonist. I guess the other side of the pain and anxiety feeding into each other is that you can have anxiety-based aggression. And that's actually another indication if a normally happy and placid animal has developed an aversion to being around humans or has become aggressive suddenly, that could well be an indication that they are experiencing pain and don't want you to come near them. They're feeling anxious that you're going to hurt them. And finally, just to mention about mental activity, when our pets are in their, I guess, normal healthy state, they get a lot of input from activities such as sniffing, playing, looking for food. And if they're feeling unwell, they may not be able to physically do those things. So it's really important to be able to provide some environmental enrichment and gentle play to our pets. And this can be anything from food toys or puzzle toys where they have to think to be able to access the food. It can be a snuffle mat, which I didn't actually put a picture of and we'll have to find one for that, where they have to hunt for food in a little mat. It can be just standing outside, being carried outside and allowed to sniff and see other dogs and see other people. It can be gentle playing with the cat. There are toys available as well for cats to get some food and just have some interaction that way. And finally, again, exercise is a form of mental stimulation. So just being able to encourage them out and about, go for a stroll in a stroller if they have a stroller available. Just anything that ignites their interest again will make them feel better in themselves, as well as have inhibitory effects on pain. So I think the next slide is going to be a summary of what we've talked about. And if we look back over what I've discussed, the things I'd like you to take away from this today are that chronic pain is a pathological type of pain. It's pain that persists for a long duration and can come about because of acute pain that is untreated. And it causes changes within the central nervous system, and it's a disease in its own right. And we need to think about those changes within the brain, within the spinal cord, and look at treating those. When we look at diagnosing chronic pain, we want to take a really thorough history, and we want to look for changes that occur over time. So we want to ask questions like, compared to when your dog or cat or rabbit was younger, what do they exercise as much for as they have done previously? Do they interact with you as they have done previously? Do they hide away? Are they trying to avoid you? Have they become more aggressive? And then looking as well at our physical examination for very, very subtle things. We want to palpate gently, and we want to look for behavioural indications that the pet finds that aversive. We just want to do that very gently. We don't want to hurt them, but we just want to see whether there's something that bothers them. And I've just put all these animals down the bottom here to remind us that pain looks different in different species. So maybe in cats, they tend to withdraw more, they tend to hide away, they tend to not want to interact with people and with other cats, and rabbits even more so. Now, with treatment, it's a combination of things. We want to treat the disease, we want to provide medications, we want to institute physical therapy, we want to encourage exercise, and we want to do things that are going to support our pet's behavior and at the same time reduce any secondary anxiety or aggression they may have as a result of being in pain. Now, I think I'm finishing a little bit early here, so we may have some extra time for some questions at the end. I've just put these learning objective questions in. So if you could think about what you would do to list 5 signs that could indicate chronic pain in any companion animal, think about what they could be. And if you have a patient that you suspect that they have chronic pain, but you're not sure, you try one treatment and it doesn't seem to work, what should you do next? How should you proceed? So thank you all very, very much for listening. And I think we're going to go to the question session next. I'd like to thank again ACTAsia and Vets for Compassion for facilitating this opportunity. I was very excited to be able to share some of my knowledge. Again, here are the WSAVA pain guidelines that can be downloaded via the QR code there. And I'll leave that up in a moment. Finally, if anyone does want to contact me, I'm very, very happy to answer specific questions. I can be contacted by email or by my website, and I also have a WeChat account. So that's the QR code for my WeChat account, and please feel free to message me directly. And if we can't understand each other, I will find someone that can help. And that's all I have to say for the moment. I think I'll turn it over to answer any questions, or if there are any comments or anything that you'd like clarified. Let's look at that.
Thanks, Dr. Keiren. That was fantastic. I was really, really pleased to see the WSAVA guidelines in there, because I don't want to brag about the ACTAsia VFC trainers, but they have already had the first webinar that we ever did in February as a test run. Was on the WSAVA guidelines, and it just shows how important pain management is, and all of these different things. I think as a non-vet, sometimes we sort of think in animal welfare, well, they need painkillers, they just need painkillers, just whatever they're in. But there's so many other things, and maybe this is an opportunity to vets to use to educate their, I don't want to say patients' owners, the people of the animals that they're looking at.
Yeah.
As well as,
I guess, guardians and carers of our pets, I think it's, if we can learn to look for the really subtle signs of whether a patient's feeling uncomfortable, then when people who care for animals start to look for those as well, suddenly it's like a light bulb goes on. It's like, oh, okay, yeah, I see what you're talking about. Absolutely. And I've noticed that since he was a puppy, he used to run around and play all the time, but now he just lies there. It's just old age. It's not just old age. There's probably a good reason why he or she has stopped doing those kinds of behaviours.
Absolutely. So I think, Annie, you are around in the background. I've hidden non-videos, and I know your internet isn't fantastic, but can you hear us, Annie?
Hi everyone, yes, I'm here.
Oh, super. So I have got the first question on the Q&A, and it's in English, so I'll
oh, hang on, I'm missing the Q&A. Let me get that up.
Oh, no, yeah, that's okay. I'll read it. Yeah, I'll read it to you so that
I've got it. There we go. If you could read it, that would be great.
Yeah, sure. So it says, Dr. Keiren, thank you for the informative talk. I've heard of some orthopedic surgeons do not use the loading dose of meloxicam as the evidence is limited, and the use of maintenance dose as the first dose instead. What are your thoughts on this?
I do go with the loading dose. I guess it's a bit naughty that it's not a very evidence-based approach, but I do like to start with an aggressive higher dose if there's no real contraindication to that in the patients. So I think that certainly it may not be very evidence-based. It's certainly covered in the recommendations by the licensing terms of meloxicam. And it really depends on the situation, but if there's not a good reason not to, I will give pain management, and I'll give more pain management than is probably needed. So I would go with the increased dose.
Lovely. Now I'll just check. I know we've got a bit of a hand over. So Ed is translating. Okay, fantastic. That's good. Just checking. Yep, that's getting back to them. Lovely. And that is our only question in the Q&A. Are there any other questions? Any other things that have particularly resonated as Dr. Keiren's gone through, or was brand new? Or any cases that you'd like to get Dr. Keiren's perspective on?
That would be absolutely fine. If anyone has a case scenario, I'd happy to talk through that and provide specific recommendations.
Yeah. And Dr. Keiren, we will share the recording of this with the attendees today. And is there, they can contact you with the WeChat QR code?
Absolutely, yes.
Yep,
yeah.
lovely.
So if anyone thinks of anything, I know sometimes if you have a whole heap of new information coming on board, just drop me a note, and I will do my best to, with my terrible Chinese, to try and answer you.
Lovely. We've got one more comment in English I can read that says, "Hi Dr. Keiren, thank you for your talk and once again for your help with Keo." That's from Ni Kang.
Yes, that's I'm very, very glad you're able to come along today. We actually have Keo the dog in the photograph with the tumour.
Oh.
We actually have his owner here today, and she's an animal behaviouralist with an interest in pain, and it was an absolute pleasure being able to be involved with making Kira's life more comfortable and more enjoyable and happier.
Oh.
So yeah, thank you for being able to come along too.
That's great. And then Annie, are you able to read this question from Jane Yin to Dr. Keiren for us?
Yes, I can do that. So Dr. Yin is asking, she says sometimes she has cases like this. So during normal examination, the dog will suddenly scream like once, but then after a while, the dog will stop screaming or anything. And then for other examination, there is no abnormal finding. There's nothing on the X-ray, and there's nothing, no pain sensation on palpation. And when when the dog is given NSAID, and sometimes the dog will improve. So she's asking, is this situation a neurological pain? Is this a sign of neurological pain?
I think that what she's described is very much chronic. It's definitely sounds like chronic pain to me, and not necessarily from a neurological cause. It could be from osteoarthritis. It could be dental pain. It could be pain from skin disease. Any type of pain that persists long enough can actually change into chronic pain. So, and as I mentioned, you don't have to. I mean, if you think about yourself as well, if someone's touching you and you're screaming with pain, how bad do you think your pain would need to be to cause you to scream out in pain? And if someone kept touching you in that same spot, causing you to scream, eventually you're going to stop screaming. So I tend to go on the first indication that when you just gently, gradually touch a patient, it can not be screaming. It can be just a look, turning to look at you. It's a bit harder to spot, but I believe I can see a worried expression on my patients' faces if they're in pain and I'm touching something that hurts. And they can express that worry as well through lip smacking or lip licking. So if you see your dog doing in response to something that when you're palpating or doing something, that is an indication that is uncomfortable or they are worried about what you're doing. I think that what you're doing, excuse me, in doing a treatment trialing a non-steroidal and seeing that there's an effect, that is a great diagnostic tool, that you've used your gut, you've used your, I guess, the art of trying to guess what's going on with your patient. You've made a correct guess and you're doing the right thing for them. So that's fantastic.
That's great. There's another question now from Jimmy. I think Annie's going to read it for you.
Yes. So this question is from Dr. Song. He's asking for chronic pain and also for patients with chronic pain and also needs NZ. In their normal daily diet management, is there anything that we need to consider? Thank you.
So if I understand the question correctly, that is that if we are administering a non-steroidal to our patients on a chronic basis, is there anything that we should change in their diet in order to, I guess, reduce complications or enhance the effect?
Yes.
Is that yeah? So I think that there are some specific diets available that contain supplements that can have an effect in helping with conditions such as osteoarthritis, and things like glucosamine supplementation. I'm having a mental blank now as to some of the other things. Having the omega fatty acids supplemented appropriately can help with controlling symptoms. In terms of reducing the effects of non-steroidals, they can have effects on the gastrointestinal tract. So ensuring that the medication is given with a meal or as directed by the specific medication can actually reduce some of the adverse effects. And there are definitely some dietary changes that can be made in terms of, I guess, cancer pain that can have an effect in the instance of specific cancers. But usually not a huge thing, but it's certainly something that can be done to help if that's within the scope of what's manageable for your patient and your practice.
Great answer there on nutrition. An anonymous attendee says, which clinical management tool do you recommend for scoring chronic pain? And then they've put examples of load, HCPI or CBPI, etc. Thank you.
So I think probably the one I reach for is the, oh no, goodness, I'm having another mental blank. The group at the University of Glasgow have actually, Numetrica. They actually have developed a quality of life index. And I think any of those is useful. I guess I tend to take, in my practice, I tend to take the pieces from each of those and I guess combine them into questions that I will ask my clients and patients. Sorry, not out chicken, out, no, busy. Thanks, Baba. Sorry.
Don't worry.
Sorry. Ooh, bad mummy now. So there's not one I specifically recommend that's better than any other. It's more finding one that you like if you want to use a tool like that for monitoring and ongoing monitoring. Certainly the Numetrica system is fantastic. However, you do need to pay for it, and it isn't the most economical way of doing things. But finding something that works for you and sticking with that, and comparing it to others, just do what works. And I think having some kind of objective measurement or systemic measurement is really important. And but they're not a specific recommendation for one over the other.
That's great. This one's from Eunice. It says, hello, Dr. Keiren. Thank you for the highly informative talk. Really enjoyed it. With regards to paracetamol, can this be given for long term for a patient where NSAIDs are contraindicated, or should it be dosed on a PRN basis? Have tried gabapentin and tramadol, but it causes too much ataxia even at reduced doses. You look like this is
okay.
a regular question.
Yeah. I think that With any chronic administration of medication, there are potential adverse effects, and typically with paracetamol, it's hepatotoxicity. So I think that's something that needs to be monitored very carefully, again, with serial blood tests, so looking at liver values and liver function. And I think it really depends on the individual patient. And what I try and do is keep the dose down as low as possible and use it on an as-needs basis. I would, in that kind of situation, I would probably use it to try and reduce the amount of gabapentin and tramadol that's being administered. The other thing that I would say is adding in something like amantadine or admitting the patient for a ketamine infusion for 24 hours could be something. I'm assuming that if that's the correct unit, so I'm assuming you're in Singapore. But if I tend to try and keep it as low as is practical. So if I can get away with it on an as-needs basis, that's great. But if it's something that really improves my patient's quality of life, I will have a frank discussion with the patient's owner or carer and let them know that, okay, with chronic paracetamol use, there is a possibility of hepatotoxicity. We can monitor it through blood tests. However, this does seem to be making a big difference for your patient's quality of life, and then just discuss the risks and benefits frankly with them and document it as well.
Very good. Now, just before the next question, I am going to share my screen just to make sure that everybody can find the QR code for the questionnaire for today. So this has got the final two questions from Dr. Keiren on there, and also just some more about the webinars, just to help us improve a little bit and see what we can tweak to get things better. So I'll just leave that on in the background and go to the next question. And this says, in patients with gastric ulceration with acute pain, like post-op enterotomy, what type of home pain relief would you recommend? Thank you.
Again, I think this is, I guess, an acute pain situation, but it would really depend on how uncomfortable your patient is. I'd probably put it to you that an enterotomy is probably less, I guess, in most situations, it's not going to be that much more painful than dissecting. So if you're doing a spay, then you're causing a lot of nociceptive input through traction on ovarian ligaments. Whereas if you're doing an enterotomy, the pain that we tend to, aside from providing, I guess, the incision through the skin and the abdominal wall, when we incise the abdominal organs, they're not particularly susceptible to cutting pain. So if you think about abdominal pain, what happens is that any kind of stretching, so bloating or cramping or distension of our abdominal organs, and particularly the hollow ones, is what gives pain in the viscera. So if you have done a fairly straightforward enterotomy, I would probably look at opioid-based pain management if that's available to you. Paracetamol would be a good choice if you're concerned about using non-steroidals. I think it really depends on the reason why the enterotomy was performed. If there's unhealthy tissue there, then I would be extremely cautious in using those. If it's a very simple enterotomy, it might be something you could consider. But certainly doing things like local anesthetic blocks, if you have access to ultrasound, it's very straightforward to do a transversus abdominis block under ultrasound guidance. And that's a very effective analgesic for the most painful part of the surgery, which is the skin and abdominal wall incision. Then adding in, perhaps some let me think. So if you're doing a local block, doing some opioids if they're available to you, adding in some paracetamol if that's something that's appropriate for the pet, and certainly I wouldn't entirely rule it out, but I would proceed with caution if it's at the top of your list.
Sure, lovely. And so the next one is back to Dr. Song. Thanks, Dr. Song, for all your questions today. I think Annie will translate this for us.
So this question is for the cats with in need of long-term use of NSAID medication management. A lot of vets here in China are very concerned about the adverse effect that this medication could have for the cat. So do you have any recommendations for Chinese vets regarding this question? Mm-hmm. How do we choose medication? How do we assess regularly for the drug adverse effect? And how do we communicate with the owners? Thank you.
Mm-hmm. So I think that's a really great question. And certainly there is a recent paper that has been published, which I can fish out. I don't think I have it available immediately. And I think that it evaluated the use of non-steroidals in cats that have renal compromise or kidney disease. I think that they found that, certainly a low dose over time didn't exacerbate things too badly. So I think there is some evidence there that does support the use of non-steroidals in these patients. At the same time, I think we do need to be cautious in how they're administered and choosing our patients carefully. So if they're in stable renal failure, then I think there is a window that they can be used with. If they are unstable and not doing very well, then I would really use them with caution. In terms of monitoring them, it really depends on what you have available to you. So if you have the access to blood tests, looking at SDMA, so one of the products released that gives a good indication of actual renal damage is really useful. As we know with renal disease, when we start to see inability to concentrate urine, elevations in urea and elevations in creatinine, we know that we've already lost most of our kidney function. We've only got about 30% of our kidney function remaining. So those things are a lot more widely accessible, and you can use those to monitor treatment progress. So looking at urea, creatinine, and urine-specific gravity, and that can be helpful. I think, again, having a frank discussion with the owners that these are the things that it's really, at the end of the day, I always put it back to the pet's owner to make the decision. It's my job to provide them with the information, and I try to the best of my ability to give them an idea of what the benefits and what the potential risks are, and phrase it as, okay, your cat has really bad osteoarthritis or gingival disease. It's suffering at the moment. It's really unhappy. Cats are unfortunately one of the species that it's really difficult to find medications that work for them because everything seems to have an adverse effect. Then discussing potentially there could be an exacerbation in this clinical problem by treating the other clinical problem. And it's again a real balancing act of finding what works in the individual situation with the individual owners, whether they feel that prolongation of duration of life is more important than providing improved quality of life. The two aren't always mutually exclusive, but that's certainly a point of discussion to get a feel for which way your pet owners may want to go.
That's lovely. Just to make everyone aware, oops, I have jumped on there on the slide. In the chat, John, thanks John for these comments. You've put some papers to reference, Gowan et al. 2011 and 2012, looking at control studies of effective long-term dosing of meloxicam with cats on joint disease. There you go. Yeah. So thank you for that.
That's the one I was looking for.
There we go. There's another one.
Yeah,
there's another one. Gowan et al. 2012, looking at meloxicam on longevity of cats with overt kidney disease. There we go. So thank you for that.
Brilliant.
That's really good. I love it that everybody's on the ball with this. Yeah. Last question, and we've got, I think, just 6 minutes left, so this should probably be perfect. This says, hi, thanks for the talk. I'm a recent vet grad here. Welcome. We love graduated vets. Well done. Just wondering how much different medication or what kind of combination you can give to manage a dog with bad osteoarthritis. I had a case where the dog is on NSAID, gabapentin, but the client said that it's not working and I've put on amantadine together with the rest. Is this too much? Thank you.
Okay, great question. So osteoarthritis is one of the most common types of chronic pain that we see. And in the dog, they tend to be more readily diagnosed with it than cats, but I think that there may still be similar amounts. It's just easier to see in dogs and we're more familiar with the signs of it. What my typical management strategy for a dog would be if I was going to do everything and I had the world's most compliant owners who wanted to do everything for their pet is to, first of all, start with a non-steroidal. That's a great starting point. If it's been a really long time that's an older dog that it appears to have been a chronic problem, I tend to start hard and then reduce back the doses of medications. So I might use a non-steroidal with some gabapentin, definitely some amantadine, and try that for 2 weeks to a month, and then gradually reduce back on some of the medications to see what the clinical state is, while keeping in contact with the pet owner to assess if there are any adverse effects. Certainly with higher dose or more intensive medication protocols, a lot of them can cause sedation or they can cause drowsiness or a bit of ataxia, which may not be ideal. And it's really, if you're thinking it's too much, it's going to depend on your patient. So you need to look at what's happening to your patient. If it's not working with what you're doing, change it up. Give it a good solid 2 weeks, I would say. And can you add in? If you have opioids available, could you add in some buprenorphine or even codeine can have some effect, not an awful lot. Is it appropriate then to hospitalize the patient and maybe trial a 24-hour infusion or give them a little pain holiday and then start the medications? So doing something like a ketamine and lidocaine infusion for over a 24-hour period might be something that's helpful to them. Then I would also look at all of the other things you can do to help a dog with osteoarthritis. So that would be to look at massage, physiotherapy, stretching exercises, improving range of motion and mobility. When we have an area of the body that doesn't get used normally, it puts strain on other areas of the body. So you can have situations whereby if you have osteoarthritis, say in the hips, you actually get discomfort in the front of the dog's body as well, because the muscles there are working overtime to take the strain off the back end. So targeting muscular tightness and pain or myofascial trigger points can be really effective, and that can be a great use of or using dry needling to try and improve that. Acupressure, massage to improve blood flow and improve flexibility and strength. And then you can also look at options to actually modify the disease process itself. And that could be something, is there something surgical that can be done to alleviate the level of discomfort? If that's not an option, could something be done in a palliative sense to reduce the sensation to the affected area? Could we do things to improve the health of the joint? So maybe adding in some, in an extreme option, maybe intra-articular hyaluronic acid injections, down to maybe supplementing with a joint supplement that's going to improve the cartilage health and the joint fluid health, adding in cartrophin or polysulfated glycosaminoglycans. So I don't think it's a matter of too much. I don't think there is such a thing as too much pain management, but it's more of a mismatch of the pain management against the pain. So if you think about it, okay, so if we have this much pain and we're giving this much pain management, then there's a mismatch. That's not great. If we keep amping it up and up and up and up and up, and we have this much pain management and this much pain, we need to dial it back down a little bit. So I hope that answers the question. I don't think it's too much if it's working. There's the take-home message there.
That's great. That's great. A tricky problem to solve, and I'm assuming that every osteoarthritis case is different as well. It's not like every time you find it, you can have this, this put together.
Yeah,
they're all individuals. Yeah. And so I think the final question is a short one from Dr. Song. Annie, are you able to read that out for us?
Yes, thank you. It's actually a comment from Dr. Song. He said, "Thank you very much for for Dr. Keiren, for organizer, for ACTAsia and everyone." And he's looking forward to the next webinar. Thank you.
Oh, thank you, Dr. Song.
Oh, wonderful.
He's jumped in ahead of me, but it's a huge thank you, Dr. Keiren, for joining us, for sharing your expertise, and hopefully, we'll be able to keep in touch after this as well, and see what else we can do together. It's been a really, really informative webinar. As a WSAVA educational partner, ACTAsia is over the moon to have this series here. I've just put the poster up for next month because we've already got it planned. And to the 18 vet trainers in China, you will know Dr. Martha from the October TTT and CPD that we did in Taiyuan last year. And she is over the moon to be able to bring internal medicine, the approach to the dog with polyuria, polydipsia, for next month. And every month we will have something slightly different, but all linked to animal welfare that we can go through that will hopefully help in your practices. So please do share this poster on, and the QR code is there. We will share it. We will see from now on if we can share a little bit more with English-speaking vets in Asia and see if we can attract more people to join as well. But thank you to everybody that's joined. But most of all, thank you for Dr. Keiren for sharing your expertise with us. And thank you to your family for letting us steal you away for the afternoon as well.
It's okay.
We appreciate it.
I think my little helper may have disappeared, but she would usually come in and say hello when her daddy's on a phone call.
Yeah, so. Of course. She can help us next time. Oh. Yeah. So thanks everybody, and I'll end the webinar now, and hopefully we'll all see you next time. Okay.
Yeah. Thank you very much everyone for your attendance, and please feel free to any questions, follow them up with me.
Wonderful. Okay. Oh. People are just leaving steadily, I think. Oh, Dr. Yin says thank you. That's nice.